Hello guys, I'm clearly audible and visible to you. Let me know in the chat box. I'm waiting for your answers. Hello guys, am I clearly audible and visible to everyone? Let me know in the chat box. Is it clearly audible? Hello, hello, hello. Good evening, good evening. Good evening, doctors. Everything is perfect, right? Okay, it's good, it's good. Just waiting for your chat also. Just a minute, guys. We'll start this session. Yes, perfect, perfect. Now, okay, guys. So I'm your Dr. Vaibhav Ahuja, and today in this session we're going to cover up all the high important topics of ophthalmology for the our FMGE 2023 December, right? Which will be going to held in the 2024, which is held into the 2025 January, right? 12th January of 2025, right? Very good. All right, perfect, perfect. Okay, everything is good, right? Okay. Let's start this session. Okay, let's start this session. If everything is perfect, let's start this session. And I'm your Dr. Vaibhav Ahuja. We'll be going to cover up your all important topics of ophthalmology in a Q&A manner, right? It is a kind of quick revision. We can say the quick revision of the topics, right? And what is the way of my teaching in the today's session? Please remember this part. I'm going to show you some important images to you or the important questions to you, and you will have to answer in this session, right? And after that, we'll be going to I will going to explain you everything, right? I always glad to hear you, sir. Very good, doctor. Very good. Okay, so Dr. Sachin is there, right? Who already passed this exam, just here for the session, right? Just for the session, he joined this. Okay, 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 Sachin. Okay, right. Let's start this session, and today's session we're gonna cover up all the important topics of respect of the ophthalmology, right? Let's start. Let's start the session, and I'm going to show you the first MCQ which is in front of your screen, right? Please try to reply. Everyone who are watching the live, please try to reply in the chat box. I'm waiting for your answers in the chat, right? I'm waiting for your answers on the chat. Please try to reply me in the chat box. The first question which is in front of you, that which is the weakest wall of the orbit? So the question is asking you guys weakest wall of orbit. Yes, the question is we want to ask you the weakest wall of the orbit. An option is given to you: the roof of the orbit, lateral wall of the orbit, medial wall of the orbit, or the floor of the orbit. Yes, so please try to reply me in the chat box. I'm checking your all the answers in the chat box on a different screen, right? Many of you are writing D, floor of the orbit. Many of you are writing the floor of the orbit, D. Okay, I'm waiting for everyone. So, guys are watching live. Please try to answer in the live session. Please try to, please try to answer. Please try to answer. It will be much better for you and me both, right? If the session is interactive, it will be good, right? Okay, okay, okay. I'm seeing many of you are replying the D only, guys. Why the D is the answer? Can anyone of you? This is the new questions, doctor. This is the new question, not the PYQ. This is not the PYQ session, guys. We already had the PYQ session on the channel of the Meduhub, so you can scroll up all the PYQs there also. I'm not talking about the PYQs. Okay, this is the new questions, right? Which is created by me, right? So this is a little bit typical questions you can say, or maybe you can say that some tricky questions are there, which I need that every student should need know this important topics of the ophthalmology, right? So that's why we are talking about it. Okay, oh, very good. So everyone is replying the D, but please remember the D is not the floor is not the weakest wall, guys. Then your answer is, sir, what will be the answer? Of course, your answer will be in this question is the answer is your medial wall. The answer is here, guys, medial wall. And yes, your medial wall is the weakest wall of the orbit. Now we have to talk about all the options. Yes, the options which are given here, right, right, right. So all the options which are come here in this we have to talk about one by one about all the MCQs or all the. So write it down please in this MCQ only, that yes, your medial wall is the weakest wall. Thank you sir for the new questions, because PYQs are coming. Yes, PYQs already we discussed already, doctor, right? And this the topics which are the high yield, which is have expected it, which is a high yield, right? High priority MCQs we are discussing here. Okay, so these have the more priority to come in the exam, right? So it's not like that. Okay, doctor. So now please listen this part. So now this medial wall is your weakest wall, and which is your strongest wall. Write it down also here. The lateral wall is your strongest wall. Of course, many of you are answered the D. So I'm clearing your also that why you answered the D, because you studied there is a blowout fracture. Yes. Yes. You are replying because of there is a fracture. Yes, which is the blowout fracture. Guys, please remember the floor fracture is known as the blowout fracture, but the floor is not the weakest wall. The weakest wall is your medial wall. Weakest wall is your medial wall, right? Now we have to talk about this all the layers one by one. Just listen this part. I'm clearing with this topic, and please remember your answer should be your medial wall. Medial wall is your correct answer. For understanding it, just before starting about the orbit, I'm going to explain a little bit about the eye. Yes, before we have to talk about the eyeball, and then of course we have to talk about the your orbit also, right? So starting with the first one, which is your eyeball. So in this eyeball, first of all, important questions which are coming from this topic of the eyeball, that there is a dimensions of the eyeball. There is the dimensions of the eyeball they are asking you. So about this dimensions of the eyeball, yes, we have to remember, sir. Yes, of course you have to remember a little bit about this theoretical or this numerical questions, right? Which is they can mention you that about this. Yes, which they can mention you. Now, what is the important? What is the important? They asked you about the first value, which is your antero-posterior diameter. Guys, what is your antero-posterior? I hope can you see this red color line which is drawn here from the anterior pole to the posterior pole, right? So this is your anterior to posterior, yes, from the starting from the anterior end and going to the posterior, right? In the starting of the cornea, and it will be going to end up, it will be going to end at the posterior pole of the retina, right? So this is known as your AP length, or you can say the anterior posterior diameter. Of course, write it down. This is also known as axial length. Yes, this is also only the synonym of this AP length is the axial length. It is known as the axial length. So this is the what is the numerically if I'm talking about, it is the length is your 24 mm. The normal, if I'm talking about the normal person, this is your 24 mm. 24 mm. The next we have the diameter. The next diameter is known as your vertical diameter. The next diameter is known as your vertical diameter. And if I'm talking about the vertical diameter, guys, this is your 23rd mm. Now if I'm talking about the vertical diameter, it should be like that from the superior to inferior, right? So this is the superior and this is the your inferior wall. Yes, so from the superior wall to the inferior wall, this is your this is your superior to inferior is your horizontal, sorry, vertical. This is the known as your superior to inferior is your vertical. And what is the length of vertical? Yes, 23 mm is the, this is the 23 mm is the diameter of your vertical diameter. Now, the many of you are getting confusing, sir, your anterior posterior or the horizontal are the same? No. Guys, the horizontal, please remember your eyeball is a ball shaped structure. Please remember it is a ball shaped structure. So what we have the anterior posterior, we have vertical, and of course we have the horizontal also. So now your question is that, sir, how it is possible in this diagram? Of course this is the 2D diagram, so you cannot see, but please remember, as I told you, this is the from the anterior posterior, we have the anterior to the posterior and we have the superior to the inferior. So of course we have the left to right. I'm writing here, this is the mean left side of the eye and this is the right side of the eye. So of course we have a horizontal diameter also, which is from the left to right, which is from the left to right. Yes or no? Right? So this left to right is known as this left to right, which is the yes, this is the known as your horizontal. And yes, horizontal diameter is your 23.5 mm. 23.5 mm is your horizontal diameter. Now, talking about the next, it is your about the circumference. What is the circumference? The whole eyeball circumference is your 75 mm. Now many of you are confusing, sir, how will be going to remember this all the values? Please write it down, one important mnemonic, which is your APHV. Yes, write it down like that. APHV. And what is the mean of APHV? Just you have to remember one value, which is your 24 mm, which is your AP length. Yes, you have to remember the 24 mm, which is your AP length. Just you have to subtract from here 0.5. Okay, from every values you have to subtract the 25 2.5. If I'm subtracting the 2.5, it will be remain 23.5, and the last, which is your 23 mm, right? So this is the your, you can remember by this mnemonic APHV, right? APHV, right? Will going to provide you, doctor, I will surely post this PDF shortly, right? Be in the session, right? So you will be understand what is the going on. Surely will going to provide you the PPT of this. Okay, PDF will be provided, no issues, right? So now you can understand this thing. These are all the horizontal diameters. Now the two important values are also there. Please make a question mark here, which is your weightage of and the volume of your one eyeball. So I'm talking about the, if each eyeball is containing the 6.5 cc, the volume of the one eyeball is just only the 6.5 cc, and the weight of the each eyeball is the 7 gram. Please remember, it is about the each. Okay, each eyeball, not the both. Please remember this. Okay, the each eyeball is having the volume of 6.5 cc, and it is having the weight of 7 gram, right? So this is the basic which you have to remember related to the questions of the eyeball, Now guys, we are moving forward for the next, which you have to remember, that about the chambers and the segments. We have to remember about the chambers and the segments. So if I'm talking about the chambers and the segment, so of course we have the two segments and we have the two chambers. For explaining this, I have to create a schematic diagram in front of you, which you have to remember, right? So what is this schematic diagram? Please remember, write it down with me in your notebooks, right? That this is the eyeball. Yes, this eyeball is further divided into the two parts. Please remember, your eyeball is going to divide it into the two further part. The first is known as your anterior segment, and the second is known as your posterior segment. The anterior segment and the posterior segment. And the anterior segment will be going to further divided into the two parts. Please remember, your anterior segment will be going to further divided into the two parts. The first, which is your anterior chamber, and the second, which is your posterior chamber. So I hope you understand this thing, that eyeball is going to divide it into the two parts, which is your anterior segment and the posterior segment. And this anterior segment is further divided into the two chambers part, which is your anterior chamber and the posterior chamber. Now listen this part. Maybe many of you are confusing still because you are reading the notes. I know you all read the notes, so you had the studied the subject, but you have little bit confusion in that what is the chambers and what is the segments. So just check it out. The first of all, I am dividing this eyeball into the two parts, which is known as the segment. So for dividing this segment, I need a landmark, right? I have to make the landmark. Then what is the landmark for the division of it? So please remember, I'm marking a imaginary line. So as I'm marking the imaginary line, you can see here I will using the this making of the imaginary line on the basis of the lens, right? So on the basis of the lens, I drawn a imaginary line. Yes, I think it's clearly visible or not. Just a minute. I'm drawing again with this black color. I think it will be visible to you. Yes, this black color is clearly visible to you. So I'm making this from the black color, you can see. So I made this imaginary line on the basis of what? On the basis of lens. Yes, on the basis of the lens. Now, can you see this imaginary line? Yes. Now, whatever the is the posterior to this imaginary line, right? Whatever the posterior to this imaginary line, this is known as your posterior segment. This is known as your posterior segment. Yes, and whatever is in the front of this line, this is known as anterior segment. This is known as anterior segment. I hope you understand this thing. So I'm writing in this schematic diagram, I'm writing here that I'm writing here the lens. So you will be going to understand this thing that yes, the eyeball is divided into the two parts on the basis of the imaginary line on the lens, which is the anterior segment and the posterior segment. Now, as we had this in the schematic diagram, we talked about it that the anterior segment will be going to further divide it. So for this further division, I'm going to zoom in this image, right? I'm going to zoom in this image little bit. So this will be going to clearly seen to you. I hope this the anterior segment is now clearly seen to you. Yes. So this is the your whole anterior segment. Now this whole anterior segment is further divided into the two parts, which is your anterior chamber and the posterior chamber. Yes, anterior chamber and the posterior chamber. For dividing it, please remember, for dividing it, I am drawing a line on the basis of the iris. You can see this red color of the line which I am marking here. Yes, this red color of line which I am marking here. So this is the division of the your chambers. Yes. So now you can see on the basis of the iris, I divided it, and on the basis of the iris, you can see whatever is the front of this imaginary line. It means whatever in between the cornea and the iris, this is known as your anterior chamber. Yes, this is known as your anterior chamber, and whatever left behind the iris and the lens, yes, this part, this is known as your posterior chamber. This is known as your posterior chamber. Yes, so we have the anterior chamber and the posterior chamber. I hope it is clearly seen to you. Just I'm drawing with the highlighter also. This yellow color which I'm drawing here, this is your anterior chamber, whole anterior chamber, right? Just a minute, right? You can see here. Yeah. So this is the your anterior, and just different color I'm using, which is the blue color. This will be the your highlighted part. Yes. This will be your posterior chamber. This will be the blue color one which I highlighted here. This is the your posterior chamber. Is it clear to you, everyone? Is it clear to you about the anterior and the posterior chambers? Right. So this is the your anterior, and this will be your posterior chamber. Yes, posterior chamber. So anterior chamber and the posterior chamber, right? So this is all about your chambers. This is all about your chambers. Is it clear to you, everyone? Let me know in the chat box. Is it clear to you, everyone? Let me know in the chat box. Quite easy now. Quite easy now. Should we move forward? Very good. Very good. So please remember, this eyeball is divided into the two parts, which is your anterior and posterior segments. And this anterior segment is further divided into the two parts, which is your anterior and posterior chamber. So I'm writing down here that on the basis of the chambers, when I'm dividing on this chambers, I'm dividing it. I made the imaginary line on the basis of iris. On the basis of iris. Yes. So I written this. So if you remember this schematic diagram, you will never be going to confuse. You will never ever will be going to confuse related to this topic, which is your chambers and the segments. Now, moving forward, the next image which you can see on your screen, this is your orbit. And what is the guys your orbit? Of course, this orbit is your bony cavity. Yes, this orbit is your hollow bony cavity. I hope everyone you had studied the anatomy, so you saw the skull. Yes, so in the skulls we have the two hollow depressions are there. Yes, in the skull we have the two hollow depressions are there, and this hollow depressions is having eyeball. Yes, you can see here, this is the hollow depression which you can see on your screen. This is the bony hollow structure. Yes, bony hollow depression, which is known as the orbit, and in this orbit we have the situated. In this orbit only we have the situation of our eyeball, right? So in the bony situation, in the bony this segment we have the in the bony cavity we have the important organ which is known as your eyeball. So this is your eyeball. Yes, this will be your eyeball, and this is the cavity which you can see over this screen. You can see this one. Yes, this hole is known as what? Orbit. This hole is known as orbit. Now, as we had talked about in the orbit, so can you see this about the orbit? So this orbit is just having only the eyeball? No, this is having your extraocular muscles also. You can see this is your extraocular muscles. Yes, so this is having your extraocular muscles also, and also it is just not only having the eyeball and the extraocular muscles, also some fatty tissues which is deposited here in this, which is known as your periorbital tissues, which is known as your periorbital tissues, right? So now I hope you understand this thing. What is the orbit? Now moving forward, about the we have to talk about the specifications of the orbit. Now, if I'm talking about the orbit, the volume of your orbit is just 30 cc. What is your volume of your 30 cc? Now, please let me know in the chat box what is the volume of the eye. What was the volume of the eye? I'm waiting for you guys. I'm waiting for you guys. Please try to reply me in the chat box. What is the volume of the eye? What is the volume of eye? Very good. It is just the 6.5 cc. It's just the 6.5 cc. Now, if I'm talking about it, the eyeball, this eyeball will be going to occupy just 1/5 part of the total volume of the orbit. Yes or no? This the orbit is the 30 cc, and you can see just eyeball is having what? Just 6.5. I'm writing here 6.5 cc. It's the eyeball, right? Very good. So it's nearby. If I'm talking about the roughly, this eyeball is occupying the from the orbit. It is a big cavity. Just the 1/5 part is covered by only the eyeball. What about the other? Yes, the others is covered by your extraocular muscles and your orbital tissue. As we talked about it, this is the orbital tissues. Now, very good. Now, talking about the important questions, which is the two important questions are here related to the orbit, as I mentioned in the MCQ, and you answered well, right? So there is a talked about this first important question, which is your thinnest wall of the orbit. Yes, which is your thinnest wall of the orbit, and the second question is here the thickest wall of the orbit. So we talked about it. Which is the thinnest? Yes, your medial wall is your thinnest wall, and your thickest wall is your lateral wall. Your thickest wall is your lateral wall. Yes, and also if I'm talking about it, the floor is commonly involved. Please remember, the floor is commonly involved in which? Blowout fracture. Blowout fracture. So covering this here only the blowout fracture, just writing down here two important things about the blowout fracture, and I hope if you studied very well, you will be going to answer me. Please tell me on MRI which sign will be going to seen in the blowout fracture. My question is this. Also, tell me the some clinical features of the blowout fracture, which is importantly they will be going to ask you about this. That from the blowout fracture they are asking you the two important questions. What will be seen on the MRIs? What will be the seen? Which sign will be going to seen on the MRI? And the second question they are asking related to your the clinical features of the blowout fracture. Please try to reply me in the chat box. Please try to reply me in the chat box. I'm waiting for your answers. What will be the your? Very good, guys. Very good. Perfect. It is your teardrop sign. Yes, what will be the teardrop? Like on the MRI, what will be going to see? Like this is the normal orbit, which is having the fully the neural your rim orbital rim will be the totally here. But in the next, which is having the fracture, what will be going to see? It is looking like there is a some dropping tear will be going to seen like that. Okay, like that. So this is the your this will be your teardrop sign. This will be your teardrop sign. Okay, very good. In the clinical feature, importantly, if I'm talking about it, there will be seen the infra orbital anesthesia. What will be seen? There will be seen the infraorbital anesthesia. And guys, what is the mean of this infraorbital anesthesia? Please listen this part. When I'm touching the patient's cheek on the same side where the patient is having the blowout fracture, I'm touching the skin on the cheek, right? Like that. So the patient is saying there is a no sensation. And why this is the no sensation? Just write it down in the bracket, because there is the damage of infraorbital nerve. There is a damage of infraorbital nerve will be going to seen. The next clinical feature which they want to ask you, which is your very good, guys, this is your diplopia. Yes, there will be the double vision will be going to see. There is a diplopia will be going to see, and very good, which is your bleeding near the eye. Yes, this is known as your ecchymosis. Yes, which is known as your ecchymosis will be going to see. And also there will be the scene of shrinkage of the globe. Yes, The globe is looking like that. The globe is going to inside. Yes, but it is a commonly not seen in every fracture. But yes, if there is a big fracture will be there. In the minor fracture, it will be not seen. In the minor fracture, you will be going to see this all the three. Yes, which is a very important for you. Is it clear to you about the blowout fracture also, guys? Very good. Now we are moving forward for the next, which is the related to your all the orbit walls, which is containing which bones. Yes. So this is the made up of the bones. Of course, the wall is made up of what? The wall is made up of the wall is made up of the bones. Now we have to talk about the orbital walls. The all orbital walls. As you already know, we have the four important walls. The medial wall is there. We have to talk about the lateral wall. We have to talk about the superior, which is the roof of the orbit, and also we have to talk about the floor. Yes, these are the only four which you have to talk about it here. Now, starting with the first one, which is the important one, which is your medial wall. Medial wall. And in this medial wall, please remember, in this medial wall, there is a frontal, the first bone which will be going to participate it here, which is your frontal process of maxilla. Yes, there is a frontal process of the maxilla. The second bone is here, which is your lacrimal bone. The second bone is your lacrimal bone. The third bone the third bone is your orbital cribriform plate, which is the part of ethmoid bone. Please remember, which is your ethmoid bone. And the last, which is the body of this sphenoid. So the four bones will be going to participate in this, which is the making your medial wall, which is your what? The first, which is your frontal process of the maxilla. Second is the lacrimal bone. The third is your cribriform plate of the orbital cribriform, we can say, which is the part of your ethmoid bone. Please remember, ethmoid bone. Yes. And the last one, which is your body of the sphenoid. So please remember, there is a clearly mentioned, yes, there is a clearly mentioned in this skull diagram. I hope you can see this is the bony cavity. Yes, this is your orbits. Yes, this both is your orbit. So as I'm going to show you this lateral image, if I'm seeing, so this will be your lateral wall, this will be your lateral wall, and this will be your medial wall, right? So this will be the medial wall. So as we have the lateral view of this image, so this should be your what? Yes, this should be your, I'm making a big box here. This will be your medial wall. Yes. So in the medial wall, as we talked about the all the important, so you can see this first bone, which is your maxilla. Yes, frontal process of the maxilla. You can see here the frontal process of maxilla is here. Yes, this is your frontal process of maxilla, which is from the purple color, right? The second one, just behind this, we have the green color bone. Number two, this is your lacrimal bone. This is the green one is your lacrimal bone. And just behind this lacrimal, just you can see behind this lacrimal, this orange color bone, which is your ethmoid bone, which is your ethmoid bone. Yes, which is your ethmoid bone. And also, please remember, now is it not clearly seen to you, but you can see from this image, you can see this is your frontal process, then lacrimal, and just behind the lacrimal, we have the ethmoid, and some part of this yellow color. There's some part of this yellow color bone is also covering here, which is the fourth one, which is your body of sphenoid, which is the fourth is the body of sphenoid. So I hope you understand this basic. Yes, the bones which are consisting in the medial wall. Just my one question to you, everyone who are watching live this session, can you tell me, as there is a four bones are participating in this medial wall, how this can be the weakest? How can it be the weakest wall? The four bones are participating here. Rather than, if I'm talking about the next bone, which is the lateral bone, in the lateral bone, just we have the two. The first, which is your zygomatic bone, and the second we have the zygomatic bone, and the second we have the greater wing of sphenoid. Yes, greater wing of sphenoid. Just two are here, and yes, as we already mentioned you, this is your strongest, or you can say, write it down, the thickest. Yes, this is the mentioned, the strongest or the thickest. So you can see in this also, in the lateral one only we have the two bone. On the lateral one we have only the two bone. The first one, which is your zygomatic bone. So you can see here this blue color one which is seen to you. This is your first, which is your zygomatic bone, and the second, this yellow color one, which is participating in the lateral wall, which is your greater wing of, your greater wing of sphenoid, which is your greater wing of sphenoid. Now, is it clear to you about the lateral wall, which is the thickest? Now, the next we have to talk about the superior wall, which is known as your roof. And of course, in the roof also we have the two important bones which are participating here. The first one, which is your orbital plate, which is your orbital plate of frontal bone, which is your orbital plate of frontal bone. And the second one we have the lesser wing of sphenoid, the lesser wing of your sphenoid. Guys, please, I'm waiting for my answer, right? Which question I asked you, please reply me in the chat box. As you can see, the lateral wall is having the two bone only, and the superior roof is also having just the two bones. Yes, but medial wall is consisting the four bones, right? And also consisting this four bones, it is the weakest. Why it is the weakest? This is my question, right? Now, as you can see here, the superior, so I have to show you all the superiors. So you can see here the first one, which is your orbital plate of the frontal bone. You can see this one is your frontal bone. Yes, this one is your frontal bone. And just from the inner side, you can see this is the second one, which is your lesser wing of sphenoid, which is, you can see, which is covering from the behind, which is your lesser wing of sphenoid, which is your lesser wing of sphenoid. Now, the talking about the last one, which is your floor, which is the floor of your orbit. And as already we talked about it, it is commonly involved in the blowout fracture. So it is having also the three important bones. The first one, which is the orbital surface of maxillary bone. Please remember, the frontal process in the medial wall, and the orbital surface is covering in your in the floor, and your orbital surface of zygomatic bone also, guys, the orbital surface of the zygomatic bone. And the third, which is the important one, which is your palatine bone, so just I'm going to show you this all the bones in this diagram. Can you see? This is the orbital surface, this is the lateral, and this is the floor. Yes, from here it is the divided into the floor. So you can see this is the maxilla. Yes, this is the first one, which is your maxillary. You can see the orbital surface of the maxillary bone, and this is the second one, which is the orbital surface of the zygomatic bone, which is the orbital surface of the zygomatic bone. And the last, which is the palatine bone. Guys, palatine bone will be not visible to you, because I hope you remember about this. That we have the palatine bone, which is making your floor, which is making your roof of your mouth. Yes, so it will be from your inferior side. Your third bone will be participating from your inferior side. I hope you remember about the palatine. We have the soft plate and the hard plate. The hard plate is from your palatine bone. Yes, yes. I'm asking about you the weakest. Why this is the weakest? Yes, why this is the thinnest? As it is constituting many bones, doctor. Yes, as it is considering many factors. Now, listen this part. I'm clearing you why it is the weakest. Please listen this part. As it is having the very four bones, I can understand you, but please can you check out in this image? These are the very small particles of the bones, right? So there is no big bone is there. It is very small particles of the bones. And the second thing, please you remember, if there is a more bone, so there is a more joints between the bone is to bone. Yes or no? As this bone is to bone will be going to make joints or not? Yes. So as this is having the more joints, so that's why this is the very weakest wall. It is having the very weakest wall. So the two regions are there. The first one, which is having the very tiny bones. As you can see, the ethmoid or the lacrimal, they have the very smallest bone. Yes, very small bones are there, right? So they don't have the strong bones there. And of course, as the bone and bone will be going to make the joints. Of course, yes. So this will be joined together as the joint. So this will be making the weakest to the medial wall. That's why our medial wall is the weakest here. Is it clear? So the question which we talked about it in the topic, which is the weakest wall. So this the weakest wall is our medial wall. Weakest wall is our medial wall. Should we move forward? Now, the second question is in front of you guys. The second question which is in front of you guys, the question number 2 is saying here that a 7-year-old girl comes with the unilateral painful proptosis. Guys, painful proptosis. Yes, what is the meaning of the painful proptosis? And even if you can reply, proptosis, it means a bulging out of eyes. Out of eye. Yes, this is the bulging out of eye. Yes. Now, yes, we have to talk about the basics, doctor, because if we don't know the basic, then how we can go with the clinical questions, right? So this is the basic of the orbit, which you have to remember, and the basic of the eyeballs I given to you in the question number 1, right? Now listen this part. The 7-year-old girl come with the unilateral painful proptosis, restricted eye movements. Guys, please note down all the key points I'm highlighting with the red color highlightation. Please remember, I'm going to highlight it. The second, she also have the lid edema. And the conjunctival congestion also. There is a conjunctival congestion will be also seen, and the chemosis is seen. Yes, chemosis and the congestion will be seen. What is your diagnosis? They are asking you about the diagnosis. As you can see, there is a unilateral painful proptosis, and they mention the clearly restricted movements of the eye, lid edema, conjunctival congestion, and the chemosis. And the option they given you about the first, which is your dacrocystitis. The second one is your preseptal cellulitis. The third one, which is your ethmoid sinusitis, and the D, which is your orbital cellulitis. So I'm waiting for your answers in the chat box, guys. Please remember the thing. It cannot be the your dacrocystitis. Why this will be the dacrocystitis? Because in the dacrocystitis there will be the no lid edema. Where will be the swelling? Will be going to see the swelling in medial canthus. Yes. And what is this medial canthus, guys? I hope you can see here. This is the nasal cavity part, right? So this is the part is known as the medial canthus. So our lacrimal sac is where? Yes, our lacrimal sac is here. So infection of the lacrimal sac will be going to cause the swelling over the medial canthus, right? So it cannot be possible. The second one, which is the your option, which is your preseptal cellulitis, right? It is also not possible. Preseptal cellulitis is also very good. The preseptal is also not possible. Why the preseptal is not possible? Because this preseptal cellulitis will be going to cause the only and only the lower part of the only and only the swelling will be at the lower part of the eye, but it is saying your lid edema. So of course the lid edema will be maybe the upper part of this eye, so of course it will be the not possible. And of course your ethmoid sinus, where you have the guys ethmoid sinus, you have ethmoid sinus on the yes, where you have the ethmoid sinus, you have the ethmoid sinus on the nasal side. So these all are not possible. So what should be your answer, guys? This will be your orbital cellulitis should be your answer. And as they mentioned you the painful proptosis, just write it down. Just write it down, one important thing. This is the most common, write it down. This is the most common cause of proptosis. Which kind of proptosis? Unilateral proptosis. This is the most common cause of unilateral. Just a minute, guys. The pencil is not working. Okay, sorry for this. This is the most common cause of unilateral proptosis in children. Okay, so the orbital cellulitis, please remember the orbital cellulitis is the most common cause of unilateral proptosis in the children. So if they clearly mentioned, this is the key point of this orbital cellulitis, and they clearly mentioned you, in the question, right? So this clearly said to you that yes, if there is a there, and of course there's all the symptoms which you have to talk about it. Please listen to this. We have to talk about it. We'll talk about this, the topic of the orbital cellulitis, so you will be going to understand. Now the answer is your orbital cellulitis, and now I'm moving forward with the you going to explain you about the explanation of the orbital cellulitis topic. So you can see in this image, I hope it is clearly seen to you. This totally edema. You can see there is a totally edema on the orbit. Yes, the eyelid, you can see the eyelid is totally swelling. Yes, the lid is the totally swelling. Yes, eyelid is having the total swelling is there. Now the first of all we have to talk about the definition. Sir, what is this orbital cellulitis? So please remember your orbital cellulitis is acute infection of the acute infection of your periorbital soft tissues. Yes, this is the your periorbital. So what we have, as we talked about now, in the orbit we have just covered, our eyeball is covering just the 1/5 part. Other what we are having, we have the extraocular muscles, and we have the your in the orbit we have the soft tissues. Yes, we have the in the orbit we have the soft tissues are there. So this is periorbital. Yes, in the periphery of this ear, in the periorbital we have the soft tissue. So this is the infection of that. So if there is an infection, what will be the clinical features we'll be going to see? Please write it down. The first one, which is the fever. Fever will be going to see in the child. The second one will be going to see the pain. Yes, pain, or we can write the painful lid swelling. Yes, we can see the painful lid swelling. Of course, the third one is your proptosis, or yes, you know about it, the proptosis, as it is the most common cause of the unilateral proptosis. The fourth one, which is your conjunctival congestion. Yes, the fifth one, we have the chemosis. Yes, we have the chemosis, right? What is the mean of, guys, chemosis? Please remember, some chemical substance, which is the exudates, we can say, which will be going to release from the eye. Yes, so this is known as the chemosis. This is also known as the chemosis. Now, tell me what should, yes, painful proptosis. Of course, painful lid swelling will be also seen, and the proptosis will be going to see. Now, tell me what should be our treatment in this part? Very easy. What should be our treatment in this part, as it is acute? Yes, eye restriction movement is the important, guys. I told you already in the MCQ, so I mentioned other. This is the restricted eye movements. How it is going to restrict it? Please listen this part. As I already told you, in the orbit what we have, this is the soft tissues which is going to cover up, and this is our eyeball, and of course there is the extraocular muscles are there. So this extraocular muscles, yes, this extraocular muscle will be not going to move, yes, because of this infection near this eye. So that's why there is a restriction of the eye movement. So this eye cannot do this movement, and at the moment of this eye there is a painful movement. Please remember, this is having the painful movement. Of course, what should be done in the treatment? Very good, guys. As there is a acute infection, so we can give the antibiotics, and we're going to add the anti-inflammatory drug. Yes, we can give the antibiotics, and we give the anti-inflammatory drug, and just add on one, which is your hot compressions. Yes, we have to add here hot compressions. Of course, the antibiotics should be given. Of course, we can give the any antibiotics. Ceftriaxone can be given. Yes, we can give the ceftriaxone also. And in the anti-inflammatory drug should be given. And of course, we're going to add the hot compressions. We're going to add the hot compressions. We'll be going to add in this patient. Right. So this is all about your orbital cellulitis. Just please remember about this, which is the important, which I already told you. This is a very important question, and make a star mark here. Right. This is your orbital cellulitis is the most common cause of unilateral proptosis in the children. Unilateral proptosis in the children. Right. Let's move forward. Let's move forward. Right. Yes, painkiller NSAID should be given, guys. NSAID should be given. Anti-inflammatory we can give. Right. Non-steroidal. Yes, anti-inflammatory drugs should be given. Very good. NSAIDs can be given. Now, we are moving forward for the next question, the third question, which is in front of your screens, that is mentioned here. The 37-year-old females come with the bilateral eye redness. Mark the all important key points, so it will be easy to diagnose it, right? And having the swelling, pain, and proptosis. Restricted eye movement, guys, all of this they mentioned. What is the diagnosis in this patient, guys? There is a not mentioned. Please remember, the orbital cellulitis cannot be the answer, because there is a no mention of the your lid swelling. Yes, there is a not mentioned, the lid is swelled up there, right? No lid swelling is mentioned there. Of course, the orbital cellulitis, the first option is given here. The second option is given the thyroid eye disease. The third option is given the orbital lymphoma, and the fourth is given the allergic conjunctivitis. I am waiting for your answers, guys, in the chat box. Please try to reply. Please try to reply in the chat box. Oh, very good. Very good, guys. The orbital cellulitis cannot be possible. Orbital cellulitis cannot be possible. Right? Doctor, not possible to allergic conjunctivitis also. Please remember, in the allergic conjunctivitis, there will be the no proptosis. Proptosis नहीं होगा वहाँ पे. Restricted eye movements नहीं होगा वहाँ पर. Right, doctor? Now, in the orbital cellulitis, as we talked about it, this is the chemosis congestion will be going to seen. But as we talked about it, this is the most common seen in the children's. Of course, it can be affected in the adults also, but there is a no mention of the unilateral. In the both eyes, we talked about the bilaterality, right? So they're asking you about the bilateral, the first thing, as they mentioned you. So it should not be there, and of course, the orbital lymphoma should not be going to cause your. This should be not going to cause your redness of this and restrictions. Now, the one which is I can see as this the female is your 37-year-old female is there. So, of course, this is going to create your case of the thyroid eye disease. And as they mentioned you the bilateral eye redness and the bilateral swelling, bilateral pain and the proptosis. So, just one important line which you have to mention here, make a star and remember this, that this is the most common cause of unilateral or bilateral, yes, unilateral or bilateral proptosis in adult, right? So if there is a adult patient, yes, if there is a adult patient is there, so you have to mention this in the adult patient. What will be mentioned? Yes, there will be the adult patient proptosis is there, unilateral or maybe the bilateral. Your answer should be your thyroid eye disease. Your thyroid eye disease should be your answer, right? Yes, of course, we'll talk about it. We talk about it just now. Just wait for it. So your answer should be your thyroid eye disease. And for this, I am going to explain you the thyroid eye disease. So now, what is this thyroid eye disease? Please mention this if I'm talking about this definition. And this is seen in your, this is seen in hyperthyroidism. Yes, where it will be going to seen? It will be seen in the hyper. Yes, of course, doctor, I am going to explain you about this thyroid eye disease. Listen this part. I'm explaining you that only, right? So this is seen in the hyperthyroidism. Now, anyone of you can tell me which kind of hyperthyroidism it will be going to seen? Of course, it will be going to seen in your Graves' disease. Yes, it will be going to seen in your Graves' disease. Now, if I'm talking about in the more, if I'm talking about this more, what will be going to happen in this thyroid ophthalmopathy? Please listen this part. As you already know about this, the Graves' disease is your autoimmune disease. So this autoimmune inflammatory cells, will become, right? So this autoimmune inflammatory cells come and deposit into the deposit into the orbital tissues. Yes, orbital soft tissues. We talked about it. So what is happening? This inflammatory cell, which is the autoimmune disease. So this inflammatory cells will be going to in your bloodstream, and it will be reached where? It will be reached into your orbit, and now it will be in your, as it will be deposited in the orbit. So what it will be going to cause? Of course, this will be going to create your infection there. So what will the patient is feeling? The patient is having the pain is there. Patient is having the pain. Painful proptosis will be there. You can see the edema. You can see there is a little bit edema. We can see. So now after that, what is happening? If there is a resolve of this inflammation, these are two things which can be happen: resolvement, or it can be possible there can be the scarring of it. Scarring of soft tissue. Yes, it can be possible, right? It can be resolvement of this issue, this inflammatory cells as we given, or it can be the scarring of. If the resolvement is there, then it will be okay to for the patient. But if there is a scarring will be there, this patient will have always live with this what? The always there is a proptosis. Yes, so there will be the permanent proptosis will be going to seen. Yes, there is a patient is having the permanently patient is having what proptosis. So you can see in this image the patient is looking like that. There is a very steady look as you can see. Yes, very good. This is your Cocker signs. You can see there is a Cocker sign. Yes. Yes, you can see there is a Cocker sign. Of course, we have the more signs there. Just remember about the Cocker sign, looking steady look. Stalwing sign also there. Stalwing sign. Yes, Cocker sign, Stalwing sign. This will be going to see. Now you can see here, if it is till the in this part, this is known as your active phase, right? And if this is the leave with the scarring, this is known as your passive phase, or you can say the scarring phase. Yes, we can say the scarring phase, or we can say the passing phase. Very good. Yes, Darlimphal sign is also seen here. Yes, very good. Yes, Darlimphal sign will be also seen here. We see the starving sign, Cocker sign, Darlimphal sign. Now, please remember Stalwing sign. Now, what can we do in this treatment part? Please remember. So, please remember the both are having the different treatment. If the patient is in the active phase, so what we can do? We can give the anti-inflammatory, or we can give the steroid, as the steroids will be going to suppress your immunity, right? Because this is the autoimmune disease, right? So inflammatory cells is your autoimmune. So steroid will be going to work on here. But if the patient is in the passive phase, now what should we do in this treatment of the passive phase? Please remember, there should be the surgery should be done. There should be the, we have to do the surgery. We have to remove this, all the scarring we have to remove, and this is the only the option which we can do in the patient of the thyroid eye disease, which is having the permanent proptosis there. You can see this eye is looking bulging outwards, right? So this, in this condition, we have to do the surgery only in the passive phase. In the passive phase, there is a no option, there is a no option, guys, for the medical management, because the scarring is there, guys. Scarring is there. Yes, so without the scarring, can, is the possible that with the scarring I can do any medical management? Of course there is a no possibilities are there for the removing this scar. So I have to do the surgery in this condition. Right, guys? Should we move forward? Very good. Cocker sign, Stalwing sign. Please remember this all, right? And as I already mentioned you, please remember this question that in the most common, this is the most common, or the thyroid eye disease is the most common cause of the unilateral or bilateral proptosis, which is seen in the adult. Now, let's move forward for the next question, and question is in front of you. Please try to reply in the chat box. Everyone who are watching live this session, please make this session a little bit interactive, right? If you are replying in the chat box, it's quite good for me and you also, right? Very good. Now, which investigation can be done on the patient who is suspected for the foreign body in the eye and had an injury occurred while using the iron welding in the workshop? So this is the which investigation cannot be done. It means they want to ask you about the contraindication. Yes, and the patient who is suspected the foreign body in the eye, guys, please remember foreign body in the eye. And with the foreign body in the eye, they mentioned that the eye injury is occurring while using the iron welding in the workshop. Yes, in a workshop. So guys, it is clearly seen to you that the foreign body is what? Foreign body is the your metal, which is your iron. Now they mention you in front of you there, they mentioned you in the front of you that option is the A, MRI, B is the CT scan, and C is the X-ray, and D is the your B scans, right? So B scan is what? B scan is in the kind of your USG. Yes, I'm mentioning clearing you this also. Yeah, USG. I hope you can understand this. In the B scan we can do. Yes, B scan तो होगा ही नहीं, right? B scan हम लोग कर सकते हैं, right? If the metal body is there, we don't have any issues. Of course, the X-ray we can do also in this condition. हम लोग X-ray भी कर सकते हैं metal. The X-ray is not having any issues with the metal, right? And of course, the same X-rays are going to use in the CT. So this should be also the possible. So what should be your answer, guys? Your answer should be the MRI, because in the MRI there is a contraindication. Yes, what is the contraindication of this MRI? There should be the no metal. Please remember. Yes, metal implant. Metal implants or foreign body. Yes, any foreign metallic foreign body or the metallic implants is the contraindicated in the MRI because the MRI, please remember guys, the name of the MRI is totally giving you the answer of it. The MRI is making your magnetic resonance in field, right? Magnetic field will be there. Yes, yes, magnetic field. So what it is creating, this MRI is creating the magnetic field. So you can understand this thing. If the magnetic field will be there, of course this iron, which is the metal here, it will be going to attract by this. Yes, so it can cause the severe injury. It can go inside of the eye, yes or no, or maybe it can go to the brain and anywhere, right? So please remember the MRI contraindication. So just I'm going to explain you about all the MRI contraindications. So first of all, just check it out. This is the iron foreign body on the cornea. You can see this is the your iron foreign body in the eye. Yes, can you see this is the iron foreign body which is clearly seen to you on the your cornea. This is the iron foreign body. So there are the some MRI contraindications which you have to remember through this. Of course, I can understand this is your radiological answer of this from the radiology. Yes, but please remember for the as per the foreign body which is in the eye, this is the most common. Yes, the iron workers. Yes, iron workers which is working with the welding, they have the most common injury of this welding machines, from the welding machines. Now listen to this part. There is an implant like the pacemakers are the contraindicated. Yes, or the intracranial aneurysms clips. Guys, please remember again the clips is there. This clip is what? The implant from the metal. Cochlear implants, cochlear implant, certain prosthetic devices which is related to your metallics, right? Implanted drug infusion pump. Drug infusion pump is also neurostimulators, bone growth stimulators, all the machineries we are talking, and the certain intrauterine contraceptive devices also, and any type of, please mention this, any type of iron based implants, right? So Kasabi implanto, which is the iron based, so we will not go. So the same as this, the iron foreign body is also, yes, this is also the iron foreign body, yes, which is inside the eye. So this iron foreign body is also the contraindication. So in this condition we cannot do the MRI in of this patient, which is the contraindicated. I hope this is clear to you everyone, right? I hope this is the clear to you everyone, right? Should we move forward? Should we move forward? Very good, very good guys. Now moving forward for the fifth question, right? The fifth question which is in front of your screen, that what is the diagnosis in a 62-year-old man with the painful, guys mention this, all the key points, painful red and diffusely swollen eyelid without the pointing pustule. Please underline this, without. Now what about the treatment of the foreign body? You want to ask about this treatment of this iron foreign body? Remove it. Remove the foreign body with 26 gauge needle. Yes, we'll take a 26 gauge needle, right? And we'll try to remove this foreign body, okay, which is available on the cornea. Yes, we'll remove this. Yes, हमको remove करना है ये iron, okay? So this is the treatment for it. So remove the foreign body with a 26 gauge needle. And now your question, maybe some of you can ask me, sir, why only the 26 gauge you mentioned? Please remember, it is a very fine and very thin, right? So this will be not going to create the some injuries on the cornea. So it will not make injury on cornea. Yes, so that's why हम ये fine needle को use करते हैं, which is the 26, right? I hope you know about the gauges, right? So जितना कम gauge होगा उतना ही ज़्यादा broad उसका क्या होगा आउटपुट होगा, राइट? यू नो अबाउट इट वेरी वेल, राइट? सो इसलिए हम बिल्कुल फाइन, जितनी पतली हमारी क्या होगी, निडल होगी, हम उससे क्या करेंगे, इसको रिमूव कर देंगे. विल गोइंग टू रिमूव विद दिस द थिननेस और द फाइन निडल, राइट? सो वहां पर ज्यादा इंजरी नहीं होगी. सो देयर इज अ वेरी लेस चांसेस टू क्रिएट द इंजरीज ऑन द to make or create the injuries on the cornea. So this will be going to safe side. Okay, so that's why we are using the 26 gauge needle. 26 gauge needle. I hope it is clear to you, Dr. Rahul. Right? Very good. Perfect. Right? Let's move forward for the next question. Now, reply me in the chat box. I'm waiting for your answer, guys. That the what is the diagnosis in the 62-year-old man which is having the with the painful red diffuse swollen eyelids and without the pointing pustule. So there is a no pointing pustule. They clearly mentioned you, and of course they mentioned you the all the important. They mentioned you all the options like the A is the chalazion, B is your external hyaluronium, which is the striae, and the C is your internal hyaluronium, and D is your pre-septal cellulitis. I'm waiting for your answers, guys. And the first of all, I'm creating here that it cannot be the A. Chalazion cannot be. Why chalazion cannot be? Because this chalazion is your painless condition. Yes, chalazion कैसा होता है? Painless. Yes, chalazion is totally painless. So in the clearly the MCQ mentioned that this is the painful. So chalazion cannot be possible. Of course, there is a diffuse salon eyelid and redness. It can be seen, right? It can be seen in the eyelid pain is in the eyelid. So it cannot be possible in the preseptal cellulitis also, because in the preseptal cellulitis we are going to see the whole lower eyelid on the lower area of the infraorbital areas will be going to affected here. Now the two option which is the very confusing is here. Many of you are answering the external hyaluronium and no one answered. Yes, one of answered the about the internal hyaluronium. Now listen this part, guys. This the answer of this question is your internal hyaluronium, right? Now you can understand this part why I created this all the MCQs, right? So for that you will be going to understand this level of the MCQs, right? Because everyone is answering the external hyaluronium, but no answer is your internal hyaluronium. The external hyaluronium cannot be, because in the external hyaluronium, please listen this part. In the external hyaluronium, I'm clearing you. It will be shows you. It will be going to show pointing pus sign. Yes, pointing pus sign वहां पर आपको show होगा. It means there is a pus will be going to pointing out to you in the external hyaluronium. And please remember, this is the only difference between the external and the internal hyaluronium. And in the internal hyaluronium, there is a no pus point sign. This is the one thing which from the clinical history or from the only question you can identify about the internal and external hyaluronium. Just listen this part. Of course, I'm going to cover up this of the three all of the three topics. The chalazion, we'll talk about the chalazion, we'll talk about the yes, we'll talk about the chalazion, we'll talk about the external hyaluronium, and we'll talk about the your internal hyaluronium also. हमको बात करना है all the topics. We'll talk about the all the topics, है ना? हम बात करेंगे सारे topics के बारे में. Now, just a minute, guys. Just a minute. There's a small error is there. Just a minute. I think is the screen is visible to you now? Is my screen is clearly visible to you? Sorry for this disturbance. Sorry for this disturbance, guys. Now tell me, is my screen is clearly visible to you? Let me know in the chat box. Screen is clearly visible. Very good. Yes. ठीक है. Now, we talked about it. We talked about it. So what will be your answer? What will be your answer in this condition? Your answer should be yes. Your answer should be your answer should be here the internal hyaluronium, right? Internal hyaluronium. Just write it down in the chalazion. It is the painless. Okay. Now, moving forward, that answer is the internal hydrolum. For understanding this external and internal hydrolum, first of all, we have to talk about the basic of this. And what is the basic of it? This is your glands of eyelids. We have to talk about the glands of the eyelids. So now, how many glands we have to do? We have the many glands inside there, but we have to talk about importantly about this four gland. The what are those four gland? Meibomian gland, the gland of G's, the gland of mole, and your accessory lacrimal gland, the accessory lacrimal gland. So we have to talk about the meibomian gland, which is also known as your tarsal gland. Also, we have to talk about the gland of G's. We have to talk about the gland of G's. We have to talk about the gland of mole and the accessory lacrimal glands. We have to talk about the accessory lacrimal glands. Now, for talking about this, all the five glands, just basically I'm talking about it. This is the tarsus gland. So it is situated at the tarsus. So the location is what? The location, it's located at the tarsus. Yes, we can say the tarsal. Where is the tarsal? Yes, on the tarsal. On the tarsal. Where is the tarsal? This is the tarsal, guys. You can see in the image, this is the tarsal. So it is above. Yes, on the tarsal it is situated. And yes, it is your modified sebaceous gland. This is your modified sebaceous gland. So as this is the modified sebaceous gland, so it will be produced what? It is producing your lipid layer of tear film. Yes, it is producing what? Yes, it is going to producing your lipid layer of your tear film. ये क्या बनाता है? Lipid layer of the tear film, and about the 20 to 30 meibomian gland is having on the each lid. So every each lid is having how many meibomian gland? We have every lid is having the 20 to 30 glands. The 20 to 30 glands we have. Now, the next we have the gland of G's, and this gland of G's is also your modified sebaceous gland, right? But the difference is here. Please remember, if I'm drawing a small diagram here, this is the eye, this is the eye lid, this is the eyelashes. Yes, this is the eyelashes. So if I'm talking about your meibomian gland, so this will be situated at the tarsus. So it is above it, right? So this is above to it, right? Just a minute, I'm drawing with the different color. So this is above to it. So you can see it is here, right? On the this. So this is your what? This is your meibomian gland. Meibomian gland, right? Now, if I'm talking about your gland of G's, so this gland of G's is having on the basis of the eyelashes. So you can see how many of eyelashes we are having on the every eyelashes base is containing what? It is containing your eye gland of G's, right? Gland of G's. So you can see this every eyelashes, base of the every eyelashes, we are having the gland of G's. And this gland of G's is open, which open at the follicle. This open into the follicle of the eyelashes. Yes, so it is opening in the, which is the hair follicle of the eyelashes we are having. It will be going to open there. Now, the next we have the gland of mole. As you know about it, the gland of mole is the modified sweat gland. So, of course, what will be the work of it? Of course, sweating. Yes, what is the work of it? Sweating, and which is open into the this is also going to open into your hair follicles. It will be also opening at the hair follicles also. Now the fourth one, which is your accessory lacrimal gland, which is the gland of Wolfing. It's also known as the gland of Wolfing. It is present near the superior border of upper tarsus. As you know about the lacrimal, so of course, what is the function of it? Making aqueous layer of tear film, making aqueous layer of the tear film, right? So this is about your this is about your gland of eyelids. I hope you understand about this, all the glands of eyelid. For now, talking about the diseases of the eyelid glands, which is the very important, we have to talk about it. They're starting with the first one, which is your internal hydrolum. And If I'm talking about the what is this internal hydrolum, write it down. It is acute infection of meibomian gland. Yes, so this is the your acute infection of the meibomian gland. So we talked about it, the meibomian gland. Of course, it is situated at the tarsus. So you can see in this image, right? You can see clearly in this image the swelling at the tarsus. Yes, swelling kahan hai ye? Swelling at the tarsus. Right now, the second thing, it is a yes, it is a acute infection of the meibomian gland. So what will be the clinical features in this patient? What will be the clinical features? Of course, redness of lid. Please remember, lid ki redness hogi, not the eye. The second thing, the painful, painful lid swelling. There will be the painful lid swelling will be seen. The third, please remember the third, which is the important, this tenderness. Tenderness is away from the margin, away from the lid margin, right? So you can see, yes, painful. So you can see this is the lid margin. ये हम lid की margin मान लेते हैं, ये eyelid की margin है. Just a minute, I'm drawing with the red color. ये lid margin है. So this is away from the lid margin. Yes, it is just away from the lid margin. Okay, this is away from the lid margin. So this is the important, that the tenderness will be there and which is away from the lid margin. Of course, there will be the, some watering will be seen from the eyes, right? This should be done. This should be, you can see in the patient of internal hydrolum. And please remember the important note: no pus point sign. So we are not going to see the pus point sign. यहाँ पर आपको कोई भी pus का point sign, pointing sign दिख रहा है क्या? नहीं. We cannot see the pus pointing sign is here. There is a no pus point sign is here. If just talking about the treatment part of it, so write it down. Of course, there will be the antibiotics. Yes, and anti-inflammatory again, because the inflammation is there. Anti-inflammation, and the last we can give the hot compression should be given in this case. Hot compression should be given in the case. And this is the your case of your internal hydrolum, which is the case of your internal hydrolum. Just the same, we have to talk about the external hydrolum also. About the talking about the external hydrolum, just remember about it. This external hydrolum is also known as the disease sty. And what is this sty or this external hydrolum? And write it down. It is the acute infection of gland of Zeiss. Yes, this is the acute infection of gland of Zeiss. This is the acute infection of gland of Zeiss. Yes, so acute gland of Zeiss. Yes, acute gland of Zeiss. This is the acute infection of the gland of Zeiss should be there. And of course, what will be the clinical features in this condition? Write it down. What will be the clinical features? Of course, the same. There is also the painful lid swelling. There will be the seen the painful lid swelling. Yes, painful lid swelling will be going to see. Of course, there will be the little bit redness on the lid. Yes, redness on lid, we can say, or the eyelid, mentioned as the eyelid. The third one, which is the, we can see here, fever also can be seen. As the infection is there, acute infection is there, fever can be seen there. And the fourth, which can be the watering from the eye. Now you are saying, sir, the same clinical features we saw in this conditions also. Just remember it. The tenderness was where at the away from the lid margin. But write it down here. The fifth one, which is the tenderness is on the lid margin. Yes, the tenderness on the lid margin. So you can see the tenderness is totally on the lid margin, and make a star here and write it down. The pus point sign is present. Yes, so you can see it is looking like that this is the your style, and it is looking that there is a pus is pointing out. Yes or no? You can see the pus point sign. Let me know in the chat box, everyone. Can you see this pus point sign clearly on this image? Right? आप लोगों को दिख रहा है ये pus point sign clearly, which is seen on the image. Right? So this is the pus point sign which is going to seen on the style, or which is, will be going to seen on the style. Right? Very good. Very good. This is the pus pointing sign, and please remember this is on the lid margin only. Rather than we talked about it, that we talked about it about the we talked about it and your yes we talked about it your internal iodulum. In the internal iodulum, this was the away from it. Yes, it is the away. Now tell me what should be done in the treatment part. Yes, what should be done in the treatment part? Just remember this. Of course, the same treatment we have to give here also. Antibiotics, anti-inflammatory, antibiotic, anti-inflammatory. Of course, hot compression, the same. Just one important thing which you have to done here. Just write it down. Star mark here, and which is write it down here. Application. And what is the application? Removal of involved eyelash. Yes, we have to remove the involved eyelashes. So which eyelash is involved here? As we talked about it, please remember, as we talked about it, कि यहाँ पर what this gland of G is at the base of eyelashes. We had the base of the eyelashes, so that it will be going to involve, of course, in this challenge. When I'm going to see in this style, there is a eye. There is I can see clearly there will be the I can see there is a hair. Yes, so this hair follicle will be going to involve. So what I will do, I will use the forceps and I will be going to remove this. I will be going to remove this hair, and this is known as your application. Yes, application is your treatment. Yes, we have to done in this condition, which is your external hydulum and the style. So please remember how to identify this. This is the two things which will be going to identify. The pus pointing sign will be present here, which is your in the style or the external hydulum. In the internal hydulum, it will be not visible. And the fifth one, which is your tenderness, is on the lid margin. Yes, in the on the lid margin. And please remember, if the pus pointing sign is not visible, absent, and tenderness away from the lid margin, away from the lid margin, it will be your yes, it will be your internal hydulum. Is it clear to you, everyone, about the external and internal hydulum? Now moving forward for the third one, which is your chalazion. And what is in the chalazion? Please write it down. It is chronic granulomatous inflammation of, it is a chronic granulomatous inflammation of meibomian gland. Yes, so of course meibomian gland. In the meibomian gland, if acute is there, please let me know in the chat box. If acute is there, if acute inflammation is there, yes, if acute inflammation is there, what is it known as? What it is known as? In the acute inflammation of the meibomian gland, yes, of course, it will be known as your internal hydulum. Very good, guys. Internal hydulum. And the chronic granulomatous inflammation, if the acute inflammation, that is the internal. If chronic, then it will be your chalazion. And you can see, of course, the chalazion is also on the your tarsal only. Where is your meibomian gland? On the tarsus. So this chalazion, this growth or swelling will be going to seen on the your yes on the your tarsus only. What will be the clinical features? What will be the guys clinical features? Please write it down. The first one, there will be the painless lid swelling. Yes or no? This will be the totally painless lid swelling. This is a totally painless lid swelling. There will be the no pain. Of course, there will be the no pain. Is there any fever or anything? No. There is a no fever. Nothing will be going to seen. And just remember, there will be the ptosis will be going to seen. And what is the ptosis? Please write it down. There will be the drooping of eyelid. Yes, drooping of eyelid. And why this is the drooping of eyelid? Because of this mass, which is the mass lesion is there, it will be going to push your eyelid downward, and this is known as your ptosis, which is your type of mechanical ptosis. Please remember, this is the type of your mechanical ptosis. Although there we can see there is a no pain, of course, so this is the painless, and please remember non-tender. This is the non-tender swelling which is away from lid margin. Yes, this is away from the lid margin. Yes, of course, it will be, of course, it is away. You can see here, this is away. Yes, it is away from the lid margin. Now, what should be done in the treatment part? Please remember, in the treatment part, you can do first, we can give the intralesional steroid injection. Steroid injection. We can give the intralesional steroid injection. If not possible, we can give the incision and curettage. We can do the I and C. We can do the incision and curettage. Now, what is this incision and curettage? Now, listen this part. For doing this incision and curettage, we can do this by this two instrument, which is the first one, which is your chalazion clamp. The second one, this is your chalazion. This is a chalazion scoop. Yes, chalazion scoop. So we have the chalazion clamp and we have the chalazion scoop. The first of all, we have to give the patient, we have to give the anesthetic, right, eye drop. And after giving this anesthetic eye drop, we have to insert this chalazion clamp inside it. So we have the two orifice of this. You can see one is the flat and one is having the opening. So this opening one will be going to inside, and the flat one will be going to pressurize from the outside. As it will be, the chalazion will be inside this clamp, will be going to screw it. You can see this is the screw. So we can screw from here and we'll be going to turnward, we'll be going to turn outward this eyelid. After the turning outward, we'll be going to give the incision on the vertical manner, right? After given this vertical incision, we'll be going to, after the given this vertical incision, we'll be going to insert this chalazion scoop inside the chalazion to scooping out the all the granulomatous material. Whatever the granulomatous material is there, we'll be going to scooping out. Yes, this it's looking like the same your ice cream scoop. Yes or no? So as we are scooping out the ice cream, the same we'll be going to use this chalazion scoop and we'll be going to scooping out this all the chalazion material which is inside it, and after that we're going to leave it like that. Will not give any suture to this incision. Okay, so this is also the sutureless surgery, right? We can say the sutureless. We don't have to give any suture, just remove all just by the making the incision. We'll have to remove the all the granulomatous material through this your scoop. Is it everyone clear to you? Right? So this is your incision and the curettage. This is your incision and the curettage, right? Which is your treatment of choice. Yes, we can write it down, the treatment of choice, TOC. Yes, treatment of choice for the chalazion, Is it clear to you, everyone? Right? Is it clear to you? Now, moving forward for the next MCQ, which is in front of your screen, and the question is asking you that what is known as misdirection of eyelashes? what is known as the misdirection of eyelashes? I'm waiting for your answers, guys, in the chat box. Options is given to you. First A, which is the dysprachiasis. Option B is the trachiasis. Option C is the madarosis. And option D is your poliosis. Option D is your poliosis. Very good, guys. You are answering very well in the chat box. Very well, guys. Of course, this misdirection of eyelashes is known as your, of course, it is known as your trachiasis. But we don't have to know only the option which I am asked you. You have to remember all the options of this list, because maybe they can ask you anything from this, all of these options, right? So let's move forward in the next slide, and we're going to talk about the explanation of this particular slide. And you can see in this image, I included all the four options. What I did, I included your all the four options, and I'm going to explain you one by one all the images. The first one, which is your trachiasis, write it down. This is your misdirection of eyelashes. Yes, which is the misdirection of eyelashes, the first one. The second one, which is the dystrachiasis. So you can see, sir, what is the mean of misdirection? So you can see always our, what is the our eyelashes root, it will be going to come upward and coming outward. Yes, you can see it will also come upward and outward like that. But now you can see it is going inside, some are going left, some are going right. Yes, it is not following the physiological directions. So this is known as the misdirection of the eyelashes. The next we are having the dystrachiasis. What is the mean of this? Of course, double layer of eyelashes. Yes, so what we are having here, we are having the double layer of your eyelashes, which is, you can see the dystrachiasis. Can you see here? You can see this is the one layer, which is the first, and the behind also you can see there is a one more layer is seen. So this is your double layer of your eyelashes, which is seen in the dystrachiasis. Guys, what do you mean by the madarosis? What is the mean by the madarosis? There is a absence of eyelashes, or you can write it down, no eyelashes. Yes, we know about it, the no eyelashes. Yes, there will be the no eyelashes. Can you see here is on the lower lid? Can you see there is a no eyelashes? Yes, you can see here there is a no eyelashes on the lower eyelid. There is on the lower eyelid, there is a no eyelashes seen on the madarosis. Yes, on the madarosis. Now the next, which is the poliosis. Yes, absence of the eyelashes is in the madarosis. What is the mean of poliosis, guys? Please remember, poliosis can be seen in the any part of the body where we have the hair, or maybe in the your scalp. You can see maybe on your beard, maybe on the face, maybe on your eyelashes. So there is the white patches of hair. Yes, there is a white patches of the hair will be going to seen in the your poliosis, on the image of poliosis. So can you see here? You can see there is the some white eyelashes. You can see here there is a some white eyelashes patches is seen to you. This is known as your poliosis. Of course, the poliosis can be on the scalp also, maybe on the face, like on the beard also can be possible. The on the beard also can be possible. But if it is in the on the eyelashes, so it is known as your poliosis, right? In the scene in the poliosis on the eye. Is it clear to you? So there is an explanation regarding this eyelashes. We have this important disease only, the trachiasis. There is the misdirection of the eyelashes. There is the dystrachiasis, where we what? Where we have the dual layer. Yes, double layer of the eyelashes. We have the madarosis, where is the absence of the eyelashes. Yes, there is a no eyelashes will be going to present, absence of the eyelashes. And the last one, which is the poliosis, where there will be the in the polyosis there will be seen the white patches. Yes, white patches of the hair will be seen here. All right. So this is about your eyelashes disease and the eyelashes. Now moving forward for the next question, which is in on your screens, that what is the diagnosis of the following image which show certain pits near the limbus, right? So there is some pits, like pit is the holes, right? Some there is the pitting holes will be going to see on the limbus, right? Pitting. I hope you know about the pitting. Yes, very good, very good, right? So the options are given here: A, which is the allergic conjunctivitis; option B is the bacterial conjunctivitis; option C is the viral conjunctivitis; and option D is your chlamydial conjunctivitis. So I'm waiting for your answers, guys. I'm waiting for your answers in the chat box. I'm waiting for your answers in the chat box. Very good. Very good, doctor. Very good. Yes, you are answering very well. I'm waiting for others also. Please, everyone who are watching live, please try to reply me in the chat box. What will be your answers? Allergic conjunctivitis, it not be possible, guys. Don't go for the allergic one. Okay, allergic conjunctivitis is not seen in this, right? In the allergic conjunctivitis, you will be going to see the cobblestone appearance. Yes, very good. Cobblestone appearance. Horner Tanta spots will be seen there, but not this. Yes, this is not the Horner Tanta. Please remember, this is not the Horner Tanta spot. Yes, reply, reply. Guys, reply. I'm waiting for your answers. Many of you replying the B, many of replying the A, many of replying C also, D also, right? Doctor, A is not possible. I already cleared you. Please remember, of course, yes, doctor. It is your chlamydial conjunctivitis. Yes, what is a chlamydial conjunctivitis? This is your trachoma. Yes, this is your trachoma, guys. Chlamydial conjunctivitis. Yes, this is your trachoma. And please remember, what is this image? Yes, this is the image of your Herbert Spitz. Yes, this is the image of your Herbert Spitz. Yes, this is your Herbert Spitz, right? Very good. Yes, the chlamydia is a trachoma. Yes, chlamydia is caused the trachoma. Yes, trachoma is caused by the chlamydia only. Now, very good, very good. We'll talk about this viral conjunctivitis, bacterial conjunctivitis, allergic conjunctivitis also, guys. No issues, no issues. So please remember, this is the answer of your chlamydial conjunctivitis. So we have to talk about in the brief about this chlamydial conjunctivitis, which is known as your trachoma, which is known as your trachoma. And guys, what is the meaning of this trachoma? Of course, the definition of this trachoma is the chronic type of keratoconjunctivitis. This is the chronic type of keratoconjunctivitis that is the primary affects. Yes, this is the primary affect the superficial epithelium of the conjunctiva and the cornea. So it will be going to involve the both of it. The cornea is also involvement there, and the conjunctiva will be going to involvement in this area. Right now, this is the chronic eye infection which is caused by your chlamydial trachomatis. So that's why by the name of trachomatis is the name is given the trachoma. Either this is the chlamydial, this is the either it is known as your chlamydial conjunctivitis also. Chlamydial conjunctivitis also. And please remember, it leads to your inflammation. It's lead to your inflammation and the scarring of it, and potentially it can cause the blindness. So it can be cause your infectious blindness. Yes, what is the cause of infectious blindness? Yes, guys, the trachoma. Yes, the trachoma is your infectious cause of the blindness. Right now, moving forward for the next, which is the important thing, which is the mode of infection. How this infection can be spread or maybe get it done on the patient. So please remember the first one, which is the direct spread. The first one, which is written here, direct spread. Guys, what is the mean of direct spread? This is contact by airborne or waterborne. Yes, this is the contacted by this chlamydial infection is contacted by the your maybe through the airborne or maybe through the waterborne. The next one, which is the vector transmission, of course, the vector is here. And what is the vector of this trachoma? This trachoma vector is through the flies, right? And the option D is here, which is the material transfer. And what is the mean of this material transfer? Yes, the material transfer is there to the contaminated fingers of the doctor, nurse, or the contaminated tonometers. And also, like maybe you use the patient who is having the trachoma and use the towel of it or handkerchief of that person, it can be caused it can be caused it. Yes, very good, very good. Yes, doctor, please remember, we'll talk about this also. Yes, the trachoma is totally eliminated. Yes, the trachoma is eliminated from the India. Yes, trachoma is eliminated from the India. We'll talk about it. We'll talk about it in the treatment part, right? Very good. Now, what will be the clinical profile of this patient? What will be the clinical profile of this patient? What will be the clinically seen in this patient? Please remember, there is an incubation period. If I'm talking about the incubation period of this patient, so the incubation period of this patient is the your from the 5 days to 21 days, 5 to 21 days. Yes, yes, very good. The contacted, this may be the contaminated fingers of the, yes, from the medical assistants also. Now, this can be through the trachoma, which can be caused by the, from the incubation period of trachoma is your 5 to 21 days, 5 to 21 days. Now, what will be the symptoms in this patient of the trachoma? The symptoms of this patient is the mild foreign body sensation. The patient is feeling that there is some foreign body inside my eye. Guys, there is a foreign body inside my eye, and the patient is feeling the irritating in the eye. Yes, so this is some foreign body sensation in there. And of course, there is a occasionally lacrimation. Yes, there is a continuous watering from the eye. The occasionally the patient is having, sometimes the continuous, they started the watering from the eye. Also, there is a slightly thickness of the eyelids. What is the mean of thickness? Yes, when the patient is waking up from the sleep, the patient is having this eyelids will be going to stick together. Yes, this is known as the sticking. Yes, sticking of it. And of course, the last one, which is the stanky mucoid disc. Of course, in this condition, the patient is getting the mucoid discharge from the eyes. So this mucus will be going to secreted from the eyes. Yes, so the mucoid discharge will be going to seen in this condition. Seen in this condition. Now, moving forward for the signs. Now, moving forward for the sign, if I'm talking about the conjunctival sign, as we talk about it, so in the conjunctival sign, there will be the congestion of the upper tarsal and the follicular conjunctiva will be seen, which is known as the conjunctival follicles. And this conjunctival follicles is known as your sago grain follicles. Yes, this is the known as your sago gain follicles. This is known as sago gain follicles. Of course, this follicular structure will be going to cause the trachomatous Herbert pits, which we'll talk about it just now, which I shown you in the image. There was the scene, the Herbert pits was going to seen to you. So just I'm going to show you this all of the images. Just give me a minute. We're going to talk about this all the images one by one. Right, with this we have to talk about it. The first one, which is your conjunctival, on the tarsal conjunctiva, there is a follicular growth. So you can see there is some follicles. Yes, elevations of this follicles, which you can see here. This is known as your sago grain follicles. This is your sago grain follicles. Yes, the sago grain follicle, of course, in the Hindi, I hope you know about the sago grain is the word your sabudana. Yes, so it's looking like that. The sabudana is on the your tarsal conjunctiva. Sabudana is on the your tarsal conjunctiva. So this is your sago grain follicles. Also, there is a, if scarring of the conjunctiva is seen, if the scarring of conjunctiva is seen, this is known as your Earl's line. So you can see on the tarsal conjunctiva, you can see this white lines. You can see there, this white line is known as, this lines is known as your Earl's line. This lines is known as your Earl's line. This lines is known as the Earl's line. Now, what is then the Herbert spirits? Please listen this part. This sago grain follicle, when the patient, please remember, Please remember, this Herbert pit is what? This Herbert pit is that when the patient of the your trachoma or the chlamydial conjunctivitis, when this patient will be going to open and close the eye, this Savogain follicle will be going to rubbing over the cornea. Yes, and due to this rubbing over the cornea, there is a Herbert's pit will be going to see. There is a Herbert pit. It will be seen on the limbus. Yes, seen on limbus. Yes, on the limbus. And guys, what is your limbus? I hope you know about the limbus. I think I don't have to explain you, but I'm writing here. This is the junction of conjunctiva. Sorry, this is the junction of conjunctiva also we can say, but the better is the junction of cornea and sclera. Yes, so where your cornea and sclera will be going to meet, this will be known as your Herbert pit. So you can see this black color, small pittings which you can see. This is your Herbert's pits. This is known as your Herbert's pit, right? So this is the Herbert's pits. Now, let's move forward, right? Let's move forward regarding the treatment part of this, right? Regarding the treatment part of it. So regarding the treatment part of the trachoma, the trachoma, the WHO, World Health Organizations, yes, WHO is given as strategy. The WHO is given a strategy. And what is this WHO strategy saying? Yes, yes, limbus is the junction between the cornea and the sclera. The WHO is given this strategy for the doing what? The doing the target is the elimination as the public health problem. And just write it down here in the box. Yes, on the 8th of the October 2024, that trachoma is eliminated from the India. Yes, your trachoma is, write it down, trachoma eliminated from India. Yes, and this 8th October 2024, WHO is given this announcement. Yes, the World Health Organization is given this thing. Please remember, they will not going to ask you about this when it is had or not. Just please remember, they can ask you this thing, which disease is eliminated from India. So the eliminated the disease is what? Your trachoma. But please remember, just not like that, sir. This disease is already eliminated, so they cannot ask you about the treatment part of it. So please remember, yes, they can easily ask you about this thing. They can easily ask about this thing. So please remember, what is the strategy is given by the WHO to eliminate this disease, to eliminate this infectious disease. For the elimination of the trachoma, the WHO is given an important the important strategy, which is your safe strategy, SAFE. And what is the S synonym? The S is going to belong here. The S is belong to your surgery for the advanced stages. And now my question to you guys, in the trachoma, which surgery, for which symptom we are doing this surgery? Please let me know in the chat box. I'm waiting for your answers. The A stands for your antibiotics, which is your azithromycin. Yes, which is your azithromycin 1 gram you have to give for the against your chlamydia trachomatis, for the chlamydia trachomatis infection. The F is stands for here for the facial cleanness. The patient should keep their face clean. Yes, the patient should have the face clean or the face wash. Yes, and last one, the E stands for your environmental hygiene. It means please go to the your good environment where you will be not going to getting this, or maybe it you're going to contaminated more person or transmitting this disease. Now my question to you guys, which surgery there is are talking about it, which surgery they are talking about here related to this? Please remember, in this trachoma, as we talk about, there is a tracheasis. Yes, so the tracheasis, which is the misdirection of the eyelashes, are seen in the trachoma only, right? In the trachoma, there is a symptom of the eyelashes is the what? Tracheasis. So if there is a misdirection of the eyelashes is seen, it will be going to rubbing over on the cornea, and it can cause your corneal scarring also, or the corneal ulcer also. So that's why we have to treat the trichiasis in this condition, right? So the safest strategy, the S stand for the surgery, which is for the advanced stages, which is the advanced disease, this is for the trichiasis. A is for the antibiotic, which is the 1 gram azithromycin. You can see here the safest strategy is what? Yes, S is for the surgery, A is for the your antibiotics, and please remember the drug of choice is what? Yes, your drug of choice is your azithromycin, 1 gram tablet. Azithromycin, 1 gram tablet should be given. And please remember this azithromycin is the drug of choice. Please remember, right? Now, the F is here for the facial cleanness and E is stand for your environmental hygiene. Environmental hygiene. All right. So this is the safe strategy for the doing the target of the elimination of your trachoma disease. But please remember this is already eliminated from the India from the October 2024. WHO has already announced this. Yes, WHO has already announced this. Now, please remember this all the important images of the Sagogain, Alsline, and your Herbert Spitz. They can ask you anything from it, right? So please remember this important images, right? Now, the next question is in front of you, right? The next question is in front of you, and the question is clearly mentioned that a 7-year-old, yes, हॉर्नर टांटा कहाँ मिलता है? ऑफ कोर्स हॉर्नर टांटा मिलता है अपने को वीकेसी में, वर्नल कैरेटोकंजक्टिवाइटिस. राहुल सिंह, विल टॉक अबाउट इट. हम उसी के बारे में बात करेंगे भी ना. वेरी गुड, हम बात करते हैं इसके बारे में ना, हम पढ़ते हैं अभी इसके बारे में. जस्ट फोकस ऑन द क्वेश्चन. I will explain you. Dr. Rahul. Right? So there is a 7-year-old boy. Just highlight all the important keywords. There is a 7-year-old boy come to the eye clinic with a symptom of redness and itching and ropey discharge from the eye, guys. He is having the ropey discharge from the eye, and the symptom will be going to worsen during the summer season, guys. Please remember it is seen in the summer season on the upper tarsal conjunctiva, where it will be going to seen on the upper tarsal conjunctiva. Some papillae are seen as it is given in the image. Please name the sign. So they are asking about you the name of this sign and what is it seen. Very good, very good. I'm getting so many answers. Please remember. Yes, very good, guys. This is your cobblestone appearance. Of course, in the allergic conjunctivitis, there is a Horner tanta will be also seen, right? And pseudoexotrons is not like that, right? Very good. Yes, of course. Buzzword is summer. Yes, buzzword is summer is there. Buzzword is boy also here. Buzzword is ear also. And the ropey discharge is a key feature. Yes, your ropey discharge is the key feature of it, right? And of course, as the image is clearly given to you, this image is of your cobblestone appearance. The image of your cobblestone appearance. And now tell me, guys, where is the cobblestone appearance is seen? Let me know in the chat box. Where is your cobblestone appearance will be going to seen? In which disease? In which disease? Name the disease. So we'll talk about the disease also, guys. Name the disease. Name the disease. I'm waiting for your answers, guys. Name the disease. I'm waiting for answers. Please try to reply me in the chat box. I'm not getting your chats. Very good. Very good. It will be seen where? It will be going to seen in the vernal keratoconjunctivitis, also known as allergic conjunctivitis, also known as spring catarrh. Yes, very good, guys. Very good. Let's talk about it in the brief. Let's talk about it in the brief. Right. Yes, so this is the answer is your cobblestone appearance. Answer is your cobblestone appearance. Now, first of all, understanding this cobblestone appearance or the conjunctivitis, we have to talk about the conjunctiva, basic conjunctiva you have to learn. Yes, so what is the conjunctiva, guys? The conjunctiva is the thin, clear membrane that covers your inner surface of eyelid and the white part of the eyeball, which is your sclera. So it is covering the two parts. Yes, it is covering the two part that it is covered your inner part of the eyelid and it is covering your anterior part of the sclera. So you can see it is covering here the inner eyelid, and of course it is covering here the scleral part. It is covering the scleral part. So this both of are known as a different, like please remember, which is covering the eyelid part, it is known as your palpebral conjunctiva. The second one, which is covering your scleral part, that is known as your bulbar conjunctiva, which is covering your whitish part of the sclera from the anterior side. This is known as your bulbar conjunctiva. So please remember this thing, because as in the question they mentioned you that there is a papillae are seen on the palpebral conjunctiva, right? So maybe you will be getting confused, sir, what is the meaning of palpebral conjunctiva? So I am going to tell you that palpebral conjunctiva is which is the under the eyelids, and what is the bulbar conjunctiva, which is seen on the your scleral part from the anterior side on the scleral part, which is the bulbar conjunctiva. And what is the conjunctival fornix, guys? This is the important, and please remember this is also the junction of palpebral and bulbar conjunctiva. Yes, this fornix is also, guys, the junction. Conjunctival fornix is there. What is the fornix, guys? Please remember, of course, inner side of it, what will be going to see? This palpebral conjunctiva, which is coming from the beneath of the your, which is coming from the below from the your your eyelid, and of course this is the scleral one. Of course this will be going to make a junction together. Yes, they will be joined together. This junction is known as your fornix. Yes, so junction between the palpebral and the bulbar conjunctiva. The junction between the palpebral and the bulbar conjunctiva is known as the fornix. Is it clear to you, everyone? Fornix is clear to you, everyone? Very good. Now moving forward. For the next is about your allergic type of conjunctivitis. And in this allergic type of conjunctivitis, which is also known as, which is the synonym, guys, please remember all the names: spring catarrh, yes, spring catarrh, vernal keratoconjunctivitis, and the short name is the VKC. And please remember this, the name is given the spring catarrh, the name is given as the spring catarrh, but it is seen in summer season. Yes, कब दिखेगा? It will most commonly seen. It will be the most commonly seen in the summer season. Please remember, summer season it will be going to seen. So don't be confused that it will be seen in the spring season. No, this is the misnomer. It will be seen in the summer. So that's why there is a key point was what? There is a key point was the buzzword point was the summer, right? Now, and what is this? Please remember, this spring catarrh or the allergic conjunctivitis is the hypersensitivity reaction type 1, which is to the exogenous allergen. So please write it down. HS1, this is the hypersensitivity type 1. As you know, in the hypersensitivity type 1, which is your acute one, yes, immediate one, we can say that immediately we're going to see the symptoms immediately in the hypersensitivity type 1. And of course it is through the exogenous allergens. And what is the kind of this exogenous allergens can be seen there? Of course these are the pollens, or it can be your grass. Yes, of course in the summer you can see there is the pollens are more over there. So this will be your what? This your exogenous allergen is what? This exogenous allergen maybe the pollen, or maybe this your exogenous pollen is your grass, right? For the grass. Now, what is the more important? This is the IgE mediated. As you already know, IgE is taking the participate in the hypersensitivity type 1, of course. And write one more thing, this is the IgE mediated, and there will be seen the eosinophils. Yes, eosinophils will be going to seen. Yes, eosinophils will be going to seen to you in this condition. Yes, eosinophils. Of course, pollens can be, and the eosinophils will be going to see in the discharge of it. Yes, more eosinophils will be going to see. Yes. Now, the important key feature, as you can see, there is the more commonly seen in the boys than the girls. The most commonly the VKC is seen in the boys. So that's why in the question they mention you clearly what there is a boy. What is the boy? Boy is the 7 years. So please remember this is the seen in the between 4 to 20 years of the ages of the boys. It will be seen in the 4 to 20 years of the ages of boys. And please remember in the clinical feature we'll be going to see there is the intense itching. The patient is having the too much itching is there. And what is the reason of this itching? Please remember there is a we have one cell which is your guys mast cell. Yes, mast cell. Now tell me what is the secreted by guys mast cell? Now tell me what is the secreted by the mast cell? What is happening? This pollens or grass which is coming on the your conjunctiva, this will be going to irritate your mast cell. Now tell me what is the secreted by the mast cell? I'm waiting for answers in the chat box. Reply me. What is the secreted by the mast cell? Tell me guys. I'm waiting for your answers. What is secreted from the mast cell? Very good. Yes, mast cell is going to, yes, mast cell will be going to secrete your histamine. Write it down. And this histamine will be going to create your itching sensation. Yes, intense itching which is seen in the patient. This is caused by your histamine. Histamine. Now, the next thing which is your cobblestone appearance. This cobblestone appearance of the papillae, guys. Now what is this papillae? Write it down. This is the flat topped elevations on tarsal conjunctiva. Yes, this is what? This is the flat topped elevation which is seen on the upper tarsal conjunctiva, mostly seen on the upper eyelid. Yes, on the upper eyelid. Now, the next we have the Horner Tanta spot. We have the Horner Tanta spot. Yes, one of the doctor was asking, sir, where it will be going to see. What was the name of the doctor? I think Dr. Rahul was it, right? Yes. Yes. So this is the Horner Tanta. Please remember in the MCQ they also mentioned the Horner. Can you see the Horner Tanta spot? But the Horner Tanta spot is not this. What is the Horner Tanta spot? This is the your Horner. Please remember this is the Horner, not the Horner. I am cutting it. This is the Horner. Yes, this is the Horner Tanta spot. Can you see this Horner Tanta spot is the your this Horner Tanta spot is the your gelatinous. This Horner Tanta spot is a gelatinous accumulation or the gelatinous growth on the limbus. Can you see limbus पर ये white silvery white patches are seen and it is the elevation growth. Yes, this is elevation growth. And why this is because of the accumulation of the eosinophils. Guys, please remember what is this gelatinous growth on the limbus? This is the accumulation of this the gelatinous white patches is the accumulation of the eosinophils which is seen on the limbus. All right, and there is a ropey discharge is the pathognomic is here. So you can see this is the pathognomic is what? The ropey discharge also. So I'm highlighting the ropey discharge also. So whatever that I highlighted in this slide, this everything is very important, guys. Everything is very important. You can see spring gutter, it is known as vernal keratoconjunctivitis seen in the summer. And write it down one important thing, which you don't have to forget. This is the recurrent type of conjunctivitis. What is the mean of guys? Recurrent. Please remember, if once the child is getting this, if once the child is affected with the vernal keratoconjunctivitis, if once the child is getting the affected with the vernal keratoconjunctivitis, the next time in the summer, again the patient may be having the allergen from this, the same from the same pollens, right? So the recurrency of this disease is too common. So this is a recurrent type of the conjunctivitis is there. All right. Now we talked about this all the things. Please remember this is your cobblestone appearance. Write it down here. Cobblestone appearance, and this is the your Horner Trantas spot. Yes, this is your Horner Trantas spots. Now, yes, again and again infection, again and again infection. Yes, more than one time. Of course, if once the child is having this, the next time also in the summer the patient can see the same. Right? Very good. Now the last thing which we left here related to your allergic conjunctivitis, which is the treatment part. And this treatment part is divided. I am dividing into the two part. This treatment part I am dividing into the two part. The first, which is the first time affected. Time affected with VKC. It means the child got this all the symptom first time. Yes, पहली बार हुआ है patient को. First time the patient is having this VKC. So we have to give the different treatment. And the patient, if we have the recurrency, so we'll give the different. Please remember, first time we'll talk about the first time VKC. If the patient is having the first time, the patient is having the vernal keratoconjunctivitis. Now, in the first time, the first drug should be given here. The first drug will be given here, eye drop of, like we can write it down, tropical antihistaminic. Antihistaminics. Yes, we'll give the tropical antihistaminics. What is the mean of tropical antihistaminic? We'll give in the eye drop form. Hana? We'll give in the eye drop form. Very good. The next, the second drug, as what will be done by the antihistaminic, guys, as the histamine is released from the mast cell. Can you understand this thing? This histamine will be getting blocked. Yes, that histamine will be getting blocked from it. The secondly drug we can give the tropically, it means the eye drop. I'm writing this ED. Yes, please remember, we can give the eye drop of steroid. And why I'm giving the steroid? Because as it is the type of one hypersensitivity reaction, the IgEs, the immunoglobulin is mediated, your immunity mediated antibody antigen reaction will be going to seen. So that's why we'll give this steroid to suppress this. Please remember this. We are going to give this steroid to suppress this. And if it is not working, we can give the immunomodulators also. Yes, immunomodulator like tacrolimus kind of the, yes, the tacrolimus. We can give this immunomodulators also can be given in this patient. And of course, we'll add the lubricants plus lubricants. Lubricants can be given in this patient. Yes, lubricants we can give. Of course, lubricant to dena hi hai, right? So lubricants can be given in this patient. So this is the treatment regimen we have to give the patient, which is the first time the coming to you. The next, which with the prophylactic treatment. Yes, what is the meaning of, guys, prophylactic? Please remember this part. The once the child got the VKC, I know the child is having this VKC disease. The patient is having the VKC disease. So of course, we can get this patient. This child can be get again this for the next summer. So before the summer only, I can give this patient to that. I can give this patient to that. I can give the mast cell stabilizer. Yes, I given the mast cell stabilizer. And what is the mast cell stabilizer, guys? The mast cell stabilizer like your sodium chromoglycate. Yes. Now you are thinking about it, sir. Why you not giving the antihistaminic is here or the steroid is here? Why you are not giving the antihistaminic is here? Why you are giving the mast cell? Just listen this part. Just listen this part. I'm going to explain you in a single slide. I hope you will be understand this thing. Just give me a minute. Right? This is in front of you. I hope you can understand this thing. If in the first, when the patient is having this, the patient is having this histamine is released. Yes, is histamine is released from where? This histamine is released from the mast cell. Yes, the patient is having this histamine is released from the mast cell, which the patient is from the first time. So of course, what I did in this condition, histamine is already showing the symptom. So I given the antihistaminic to block this histaminic with the antihistaminics. Yes, I given the antihistaminics, But now in this time, the next time I know about it, the patient is having the allergens or the allergy with this pollens. So that's why, should I wait for this thing? Should I wait for this thing that patient is having the symptom, then I will give the antihistaminic? No. So what I given the mast cell stabilizer. And this mast cell stabilizers, what will be do? They will be going to block this mast cell. Now tell me, if mast cell is getting deactivated, is there chances that histamine will be going to secrete it? If no histamine, there will be the no symptom. Please remember, agar histamine secrete nahi hoga with the mast cell stabilizer, so if there is a no histamine, agar histamine secrete nahi ho raha hai, so this mast cell will be not there, histamine will be not secreted. If histamine is not secreted, there will be the no itching, there will be the no hypersensitivity reaction, there will be the no this VKC will be going to seen, and only by this giving this prophylactic drug we can do this, that there will be the no, there is a no issues in the VKC. Is it clear to you, everyone? Right? Tell me in the chat box. Is it clear to you about everyone about this? Let me know in the chat box. Right? Okay, guys. So we are ending this session here only with this all the important MCQs which we talked about it, which is having the more chances to come into your exams. In the last of this session, I'm mentioning you, if you have any queries related to the ophthalmology, right, and regarding this session, so you guys can contact me directly on my Instagram, which is the Dr. Vaibhav Ahuja. Yes, dr. Vaibhav Ahuja is the my Instagram username, and also you guys can contact me on the directly to my many of you are not using the Instagram, right? So you are using the Telegram. So this is the my personal Telegram username, dr. Vaibhav Ahuja. There is a no dot. Yes, just the dot is added in the Instagram, and on the Telegram we don't have the dot. So this is the my the Telegram username, right? Please remember about it. Of course, the giant papillary conjunctivitis is also important. We're going to cover up in the next sessions, right? In the next sessions of the ophthalmology. Okay, many things left, right? We left with the cataract, we left with the glaucoma, right? Squint, neuro-ophthalmology, retina. Yes, of course, we're going to talk up in this series of it. Okay, just for the today's this session will be going to end it here only, and I hope you enjoyed this session. Yes, I hope you enjoyed this session, right? And of course, this will be going to help you in your exams, right? Okay, guys. Okay, guys. If you have any queries, you guys can contact me anytime. I will be going to help out you in this. I will be going to help out you in this. Okay, guys. Okay, guys. Thank you so much. Thank you so much for this session. Okay. All right. Ending this session. Goodbye. Good night.